Controlled medications, a strategy for safe use in psychiatry. When discussing controlled medications in psychiatric practice, we are essentially addressing three main categories that constitute the bulk of our prescribing. First, stimulants, medications that enhance dopamine activity in the brain through two primary mechanisms. Some employ what we might say the lock strategy, blocking the dopamine transporter, essentially preventing dopamine reuptake after synaptic release. The methylphenidate family exemplifies this mechanism. Others utilize the crowbar strategy, forcing vesicular release of stored dopamine from presynaptic terminals. The amphetamine family operates through this mechanism. To this category, we might add the alertness-promoting medication modafinil and armodafinil. These two demonstrate weak dopamine reuptake inhibition, some activity on orexin pathways that regulate wakefulness, and several other mechanisms that remain incompletely characterized. Second group, anti-anxiety medications, specifically the benzodiazepine class. These agents work by positive allosteric modulation of GABA-A receptor, dramatically enhancing the receptor's activity so endogenous GABA becomes more powerful. This potentiation of GABAergic neurotransmission produces anxiolytic, sedative, myorelaxant, and anticonvulsant effects. Third group are the sleep medications, which comprise of three pharmacological distinct groups. Certain benzodiazepines, which are marketed specifically for hypnotic indications like temazepam and triazolam, which function through GABA-A receptor mechanism previously described. The benzodiazepine receptor agonist, or the Z drugs, zolpidem, esopiclone, zaleplone, demonstrate preferential binding to the alpha-1 subunit of the GABA-A receptor complex, theoretically providing a more selective sedation with reduced anxiolytic, myorelaxant, and anticonvulsant properties. Whether this subunit selectivity translates to clinically meaningful differences in dependence liability remains debated, but they are still controlled medications. Finally, the orexin receptor antagonists, suvorexant, daridorexant, and lemborexant, represent a mechanistically novel approach. Orexin neuropeptides activate excitatory and arousal systems essential for maintaining wakefulness. These antagonists block orexin signaling, thereby preventing activation of wakefulness circuits rather than enhancing inhibitory tone, a fundamentally different pharmacological strategy for inducing sleep. The epidemiology of use and diversion. The volume of controlled medications utilization in psychiatry is substantial and demonstrates concerning trajectories. Current CDC data indicates approximately 30 million Americans receive benzodiazepine prescriptions annually. Stimulant prescriptions have increased dramatically from approximately 6 million in 2000 to over 40 million prescriptions annually as of 2023. This represents a 567% increase over a period during which population growth was only 18%, indicating that factors beyond population expansion are driving utilization. Sleep medication prescriptions approximately 55 million annually across all drug classes. Diversion rates. The proportion of legitimately prescribed controlled medications entering non-medical channels represent a significant public health concern. DEA estimates suggest approximately 16 to 20% of prescription stimulants are diverted through sale, distribution, or trade. Benzodiazepines demonstrate similar rates, 15 to 18% diversion. Sleep medications show somewhat lower diversion, 8 to 12%, likely reflecting a lower recreational demand and resale value. The risks associated with non-prescribed use vary by pharmacological class, but are uniformly serious. Stimulants carry cardiovascular risk, myocardial infarction, cerebrovascular accident, arrhythmias, particularly in individuals with undiagnosed cardiac pathology. Addiction liability is substantial, with high dose use associated with paranoia, psychosis, and dangerous polysubstance interactions. Benzodiazepines demonstrate particular lethality in combination with alcohol or opioids, contributing to tens of thousands of annual fatalities. They produce profound physical dependence with abrupt cessation precipitating potentially fatal withdrawal seizures. Cognitive impairment contributes to accidents, falls, and impaired judgment, leading to high-risk behaviors. Sleep medications, particularly the Z drugs, have been associated with complex automatism behaviors, driving, cooking, engaging in sexual activity, performed in states of incomplete consciousness with subsequent amnesia. Serious injuries and fatalities have been documented from these parasomnias. The shortage crisis. Recent years have witnessed persistent stimulants shortages affecting clinical practice nationwide. These shortages reflect multiple etiologic factors. The primary cause involves deliberate production quotas imposed by the Drug Enforcement Administration. The DEA establishes annual manufacturing limits for controlled substances based on projected medical demands. These quotas have consistently underestimated actual requirements, particularly as ADHD diagnosis and treatment prevalence have increased. Upward quota adjustments have lagged substantially behind demand growth. Manufacturing compliance issues compound the problem. Controlled substances production operates under extraordinarily stringent regulatory oversight, exceeding requirements for non-controlled pharmaceuticals. Any deviation from good manufacturing practice standards, quality control anomalies, or adverse inspection findings can precipitate production suspension lasting months. Several major manufacturers have experienced extended shutdown for such issues. Additionally, precursor chemical supply chain have experienced disruption from geopolitical factors, pandemic-related manufacturing interruptions, and increased global demand. The resultant impact on patients with legitimate prescriptions has been substantial, creating treatment interruptions with significant academic, occupational, and functional consequences. This represents a systemic failure with cascading adverse effects on patients' care and clinical confidence in treatment continuity. Benzodiazepine shortages occur less frequent, but have affected generic formulations, typically secondary to manufacturing disruptions at high-volume production facilities. Mensana Center Prescribing Protocol for Controlled Medications. The following strategy represents mandatory prescribing requirements at Mensana Center established for regulatory compliance and patient safety. Rule number 1, FDA-approved indication required. Patients must present with a diagnosis for which the proposed controlled medications carries FDA approval. Stimulants are prescribed for attention deficit hyperactivity disorder or narcolepsy. Benzodiazepines are prescribed for anxiety disorders and panic disorder. Hypnotics are prescribed for insomnia disorder. Off-label prescribing of controlled substances occurs only in exceptional, well-documented circumstances with clear clinical rationale documented. Rule number 2, documentation of non-controlled treatment trials. Prior to controlled medication initiation, non-controlled therapeutic alternatives must have been attempted with documented inadequate response or contraindication. The exception involves patients transferring to our care established on controlled medications with documented efficacy and absence of misuse indicators. Such patients may continue established regimens during stable periods, though future complications will necessitate non-controlled alternative considerations. For ADHD, this requires trials of atomoxetine, viloxazine, guanfacine, or bupropion before stimulant consideration. For anxiety disorders, SSRI, buspirone, or hydroxyzine must be attempted before benzodiazepines. For insomnia, trazodone, mirtazapine, doxepin, ramelteon should precede controlled hypnotics. Rule number 3, absolute abstinence from non-prescribed psychoactive substances. This represents a non-negotiable requirement. While receiving controlled medications and optimally at all times, patients must maintain complete abstinence from all illicit substances, cannabis, alcohol, non-prescribed controlled medications, irrespective of similarity to prescribed agents. The medical rationale involves dramatically elevated risks of adverse events, overdose, impaired judgment, and accidents when controlled medications are combined with other psychoactive substances. The regulatory rationale involves prescriber liability exposure and potential loss of prescribing privileges when controlled medications are provided to individuals concurrently using other substances. Rule number 4, prohibition of early refills. Patient must never deplete controlled medication supplies prior to the prescribed refill date. Prescriptions specify exact quantities intended to last defined periods of time. Early depletion indicates either misuse or diversion, both constituting grounds for immediate discontinuation. Common explanations for premature depletion include accidental loss, dropping in the sink, spills, theft by third parties. This requires police report. Unreported theft raises questions regarding actual disposition. Confiscation by authorities, for example, airport security, law enforcement. That does not occur with properly labeled prescription containers. If occurring, documentation must be provided. Contamination or accidental destruction. While these incidents may occur, you have to be very suspicious when you hear this kind of explanation and remind the patients that they must treat these tablets as if they are made of gold. If they would have in their possession a nugget made of gold, they for sure are not going to drop it in the sink or let it be licked by dogs and other ridiculous explanation. The sole acceptable rationale for replacing lost or stolen medication involves a police report explicitly documenting the loss and identifying the medication by name. Rule number 5, maximum FDA-approved dosing. No patient will receive prescriptions exceeding the maximum recommended dose specified in the FDA-approved package labeling. While research literature may suggest efficacy at supramaximal doses for certain conditions, such studies do not modify our prescribing parameters. Requirements for dose exceeding FDA maximum suggest diagnostic reconsideration, inadequate trials of alternative agents, or the development of tolerance. Rule number 6, stimulant-specific guidelines. Stimulants at therapeutic dosages do not produce clinically significant physical withdrawal syndromes when stopped abruptly. This point requires emphasis given widespread misinformation. Stimulants are explicitly designed for intermittent administration, 5 days per week, during school or work, with weekend cessation represents the standard acceptable practice. Discontinuation after prolonged therapeutic dose does not precipitate the dangerous withdrawal phenomena observed with benzodiazepines or opioids. Patients may experience transient fatigue, reduced concentration, or irritability lasting several days, but these symptoms are not medically dangerous and resolve spontaneously if they happen at all. Therefore, running out of stimulants should never be treated as urgent. Parents depleting supplies due to missed appointments or delayed refills will be scheduled for standard appointments. Emergency stimulant prescribing outside the established appointments is not really necessary. Rule number 7, prohibition of non-prescribed controlled substance use. Utilizing controlled medications prescribed to other individuals, even when identical to the patient's own prescription in medication and dosages, constitutes use of non-prescribed controlled substances. This practice also represents federal criminal activity. Discovery of such behavior triggers the consequences outlined below. Rule number 8, urine toxicology requirements. Urine toxicology screening may be required under various protocols with each controlled substance prescription or a random monthly testing for 6 months period or periodically when irregularities are suspected. Toxicology serves as a dual verification purpose, confirming prescribed medication consumption, substance should be detectable in urine, and excluding contraindicated substance use. Testing must be completed within 48 hours of request. Failure to complete testing within this time frame will be interpreted as a positive result, indicating substance use, with automatic implementation of countermeasures described below. No extensions or accommodations for scheduling conflicts, travel, or other obligations will be granted. Inability to complete testing within 48 hours of request indicates unsuitability for controlled medication treatment. The testing objectives must be understood clearly. We are attempting to document negative results, not positive findings. Patients aware of imminent positive results due to substance use may simply disclose this information. Testing becomes unnecessary, and countermeasures proceed directly from that point on. Honesty, while not preventing consequences, eliminates pretense and conserves clinical resources. Consequences of protocol violations. Protocol violations, following a clear explanation and documentation, trigger one or more of the following responses. Option number 1, immediate discontinuation with medically indicated taper. For stimulants, immediate cessation can occur. As previously explained, therapeutic dose stimulant discontinuation does not create dangerous withdrawal, rendering immediate cessation medically safe. For benzodiazepines or controlled hypnotics, tapering protocols are implemented. Rapid tapers span 1 week for low dose or short duration use. Extended tapers can span 3 months for high dose or long-term use. Taper schedules are determined by medical necessity, not patient's preference. Following discontinuation, patients must demonstrate 1 year of documented sobriety supported by periodic toxicology screen before controlled medications can be considered. This requirement reflects recognition that individuals misusing one controlled substance demonstrate elevated risk for subsequent misuse, necessitating substantial demonstrated stability before acceptable risk resumption. Option number 2, dose reduction with intensive monitoring. Benzodiazepines and hypnotics only. For benzodiazepines or controlled sleep medications, an alternative to complete discontinuation involves dose reduction to 50 to 75% of prescribed amounts, continuing for a period the original prescription should have covered. For example, premature 20-day depletion of a 30-day prescription results in reduced dosing sufficient for the remaining 10 days, followed by weekly dispensing for 1 to 3 months with mandatory toxicology at each visit. This option applies exclusively to initial protocol violations when compelling medical or safety considerations render immediate discontinuation unadvisable. Option number 3, mandatory toxicology for unexplained medication absence. Patients presenting without expected benzodiazepines or hypnotic detection, for instance, requesting early refills while claiming medication depletion when therapeutic levels should remain detectable, require immediate urine toxicology. Unexpected medication absence from urine suggests either diversion, sale or distribution, or erratic consumption pattern indicating misuse. Addressing anticipated objections. Two accusations occasionally arise when controlled medications are discontinued. Patient may accuse you of treatment refusal. This is inaccurate. Controlled medication prescribing is being declined, but treatment is not being refused. Non-controlled alternatives are offered. For ADHD, these include atomoxetine, viloxazine, bupropion, and behavioral interventions. For anxiety, these include SSRIs, buspirone, hydroxyzine, and psychotherapy. For insomnia, these include trazodone, mirtazapine, doxepin, rameltion, cognitive behavioral therapy for insomnia, and sleep hygiene intervention. If the patient declines these alternatives, that represents their autonomous choice, but does not constitute abandonment or treatment refusal by the clinician. Treatment is being offered and the patient declines, if that is the case. Another accusation possible is the assertion of a dangerous abrupt discontinuation. This assertion is also inaccurate. When benzodiazepines or controlled hypnotics are discontinued following protocol violations, medically supervised tapers spanning 1 week to 3 months are implemented. Appropriately designed medical tapers do not constitute abrupt discontinuation. Abrupt discontinuation would involve immediate cessation of chronic benzodiazepine therapy without taper, a practice not employed anywhere. Our practice involves medically supervised tapering that may proceed more rapidly than patient prefers, but remains medically appropriate and safe. The underlying rationale is patient protection. The rationale for strict protocol enforcement requires explicit articulation. This framework does not represent punitive measure or moral judgment. This represents protection against catastrophic outcomes. Statistical data regarding substance use disorder outcomes are unambiguous and severe. Unemployment rates among individuals with substance use disorder are 2 to 3 times higher than general population rates. This is not a marginally elevated rate, but it is substantially elevated rate. Relationships, divorce rates, and relationship dissolution demonstrates dramatic elevations. Family structures fragment. Children experience trauma. Social networks collapse. Health, medical complications from substance use are extensive. Hepatic disease, cardiovascular disease, infectious disease, trauma from impaired judgment. Average life expectancy decreases by 10 to 20 years. Legal consequences, arrest rates, incarceration rates, legal costs, permanent criminal records affecting employment and housing access, driving under influence, drug possession charges, escalating severity, financial devastation, direct substance acquisition cost, indirect cost from employment loss, legal fees, medical expenses, credit destruction, housing loss, bankruptcy, insurmountable debt accumulation. Mortality, overdose deaths, deaths by accident, suicide rates 10 to 20 times higher than general population. These are CDC documented statistics, not exaggeration. When patients demonstrate substance misuse, warning signs, premature medication depletion, non-prescribed substance use, erratic behavior, clinical duty requires intervention prior to entry into these catastrophic outcome categories. Risk amplifications occurs when comorbid psychiatric illness coexists with substance misuse. This combination demonstrates synergistically worse outcomes than either condition independently. Strict protocol enforcement, mandatory toxicology, and controlled medication discontinuation, despite patients' protests, represent efforts to prevent patients from becoming additional statistics in the catastrophic outcomes that previously I described. Alternative care arrangements. If the patient prefers a clinician who will overlook substance misuse indicators and continue controlled medication prescribing regardless of concerning behaviors, that patient must identify alternative care. The patient must contact insurance member services requesting provider transfer. This represents the patient's autonomous right, and transfer will be facilitated with appropriate treatment history documentation if the patient requests it. However, such clinicians will not be found at Mensana Center. Our providers uniformly decline to compromise patients' lives and well-being by continuing controlled substances while disregarding clear misuse indicators. This position is non-negotiable and not subject to debate. This represents established policy grounded in medical ethics, regulatory requirements, and decades of empirical data regarding outcomes when prescribers ignore warning signals. Now, some closing observations. Controlled medications, when utilized properly, provide genuinely clinical benefits. Patients with ADHD achieve dramatic academic and occupational improvement with stimulant therapy. Patients with debilitating anxiety disorder regain function through short-term, as-needed use of benzodiazepine as a bridge to more definitive treatments. Patients with chronic insomnia finally achieve restorative sleep. These medications serve legitimate therapeutic purposes and benefit patients substantially. However, they also carry significant risk. They demonstrate addiction liability. They are diverted. They are misused. Consequent harms are severe, affecting individual patients, broader society, the medical system, and every patient legitimately requiring these medications but facing increasing restrictions due to widespread misuse patterns. The outlined protocols are designed to provide access for patients capable of safe utilization while identifying and intervening early when patients cannot. This represents the balance we must strike as responsible prescribers. This protocol defines the standard of care patients should expect at Mensana Center. If the patient can function within these parameters, controlled medications may represent appropriate treatment options. If the patient cannot, we will identify alternatives that maintain safety without the risk these medications entail. The decision ultimately rests with the patient. They comply with these requirements, they will continue to have access to their medications. They do not, then controlled medications cannot be used in that particular situation.